invite Dr. Varsha. She completed her MS and from CMC Vellore and fellowship in oculoplasty from Shankar Nethralaya. Currently, she is a consultant in the Department of Oculoplasty in Shankar Nethralaya. Madam will be talking on endoscopic revolution in dacryology. Over to you.
Thank you so much for the kind introduction. Special thanks to Dr. Ann and the organizing committee for giving me this wonderful opportunity. It's great to be here in Cochin. So I'd be talking about the endoscopic revolution in dacryology. There has been a transformation in dacryology in the past few decades. And surprisingly, endonasal DCR was described many decades prior to external DCR, the first one. So this was due to the difficult visualization and inadequate bone and soft tissue removal. Endonasal DCR was not in vogue at that point in time. It is only after the advent of the rigid endoscope in 1970s, now the endoscope has been widely used for almost all lacrimal drainage disorders. So the nasal endoscopic viewing system consists of many parts to it, the most important one being the rigid endoscope. So there are two diameters in that, the 4 mm and the 2.7 mm diameter. The larger diameter is used in adults, whereas the smaller one is preferred for pediatric patients because during probing the space that we work in is very less. And there are different angulations available, 0, 30, 45, 70, 90, etc. But 0 and 30 degree angulations are commonly used. The 30 degree one helps us to have a better view of the lateral wall of the nose. So a little bit on the normal nasal anatomy. Here you can see the middle turbinate and the root of the middle turbinate. Inferior to it is the inferior meatus. Then this is the inferior turbinate, and inferior to the inferior turbinate is the inferior meatus. So we need to know the axilla of the middle turbinate, as you can see very clearly here, and also the maxillary line, which is basically the junction of the frontal process of the maxilla and the lacrimal bone. So this surgical anatomy everyone should keep in mind so that we become good endoscopic surgeons. And this is a short video. So here you can again see the middle turbinate and the root of the middle turbinate here. Now I'm just trying to maneuver it below the middle turbinate. This is the second pass, and we have a look at the throat as well. And here you can see the space below the inferior turbinate is less, so I'm elevating the inferior turbinate with the periosteal elevator, and then the rigid endoscope is passed below the inferior turbinate. So this is the first pass. So the first and the second pass should be done for all the cases. Nowadays, the use of the endoscope is a dictum in conjunctival nasolacrimal duct obstructions, both in simple as well as complex NLDOs. So this is a short video of the regular probing that we do in the office by stretching the upper lid typically and placing the probe. So we always combine this with the endoscopic viewing of the probe. Here gently I am elevating the inferior turbinate and the probe is visualized coming out of the nasolacrimal duct. Then serial dilations of the nasolacrimal duct is done with thicker probes so that the success rate improves. Then the syringing is also done to visualize the dye in the inferior meatus. Now, in cases of difficult probing or older children or failed probing in the past, as you know, the success rate is around 80 to 90%. We can use bicanalicular as well as monocanalicular intubation sets. What I usually prefer is a monocanalicular intubation test. This is a self-threading monocanalicular stent. Here I'm using a FCI Rittling monocanalicular stent. I have no financial disclosure. So this basically has a probe and it has a stillet in it. And as you can see, there is this black thread which is made up of PEEK, which is in continuation with the silicone intubation tube. So this black thread can be threaded into the probe, and as you pull the black thread out through the nasal cavity, the silicone tube will be placed in the passage. So here you can see the probing has been successful in the inferior meatus. You can visualize the probe. And here syringing is done, and you can see the dye coming out of the NLD opening. Now I am doing the probing with the Rittling monocanaliclar stent. The stillet has been removed, and I will thread it with the black thread. And you can visualize the black thread over there. And we hook it out with the instrument which is provided with the set. And as you pull it out through the nasal cavity, the silicone tube will be left in place. Now, why I prefer the monocanaliclar stent is basically for 2-3 reasons. One is when we use a bicanalicular stent, when we leave it for 3 weeks or so, 3 to 4 weeks, when we remove it, by the time the puncta can also get damaged, there's splaying of the puncta, many issues can happen. And also we need to give general anesthesia for the child when we have to remove the bicanalicular stent. So the advantage of a monocanalicular stent is I can just remove it in the OPD itself. Just hold down the baby for a few minutes and remove it with the forceps. And of course, we can use bicanalicular stents as well. The option is to the surgeon. So this has a specific role, endoscope, in congenital dacryocele especially, because there can be intranasal cysts. Then you need to marsupialize the cyst as well. And also in other cases like facial clefts, cerebral palsy patients and all that, also we need to use the endoscope. So we all know that the endoscopic DCR has been widely advocated in primary nasolacrimal duct obstruction, but it can also be used in secondary nasolacrimal duct obstructions, say in traumatic cases and also in neoplasms. Special considerations for bilateral NLDO obstruction, wherein one can advocate endoscopic DCR in the same sitting to both sides, and also in acute dacrocystitis in case the patient has an impending intraocular procedure, say an RD or some early intraocular procedure has to be done, then we cannot do an external DCR because of the excessive inflammation. So we can try an endoscopic DCR, so the success rates are better. So sorry, this video is not paying. So the pre-op nasal endoscopy is very crucial for all NLD obstructions in adults. So the such conditions such as deviated nasal septum, polyps can be seen, and as rightly discussed by my other colleagues, we need to address that, otherwise the DCR might fail. So this is a patient wherein you can see the middle turbinate very clearly. It looks nearly normal. But as you pass the probe into the middle meatus, this also looks pretty okay. Now you can see a fleshy growth, grayish mass with white spots on it in the inferior meatus as well. So this is basically a rhinosporidiasis, a similar case as presented by Dr. Ann. So it is very crucial to do a nasal endoscopy for all primary acquired nasolacrimal duct obstruction patients. Oh, this is a short video of the endoscopic endonasal DCR. Here an incision is made. The incision is made about 10 to 15 millimeters anterior to the root of the middle turbinate, about 2/3 the length of the middle turbinate. So initially I used to use a elevator to just make a small groove to make the location of the incision, and then go ahead with an incision using a crescent blade. That is what I prefer to use. Then we can elevate the mucosa with the elevator, and the maxillary groove is seen, and the punching is started. So during the initial stages, the punching is the one which is a little tricky, but with experience we all get better. So here the nasal mucosa flaps are trimmed, and you can see the lacrimal sac being exposed, but it is not completely exposed. It has to be exposed very well so that the patency is ensured. So the superior portion of the ostium is very important. So here it is being punched. And we have the luxury of the power drill in our institute. So the superior portion is again drilled so that the ostium is quite large. And now you can see very well that the lacrimal sac is completely exposed, and you can see the probe tenting through the sac, and the probe is always kept horizontal so that we know that there is an adequate ostium will be formed. Then all the chips of the residual body are removed. Here again we are using a crescent plate to open up the sac. You can see the probe being visualized. Then the sac's flaps are positioned like an open book so that it is in contact with the nasal mucosa. So this is a video of a child who has undergone a bicanalicular intubation. He is diagnosed to have a bicanalicular tear, as you can see. So just like a regular probing, we pass the Crawford stents. So after passing, do a regular probing sort of a thing, and then we pull out the tubes through the nasal cavity. So in traumatic NLD obstructions, when the anatomy is grossly distorted, then again we can take the assistance of an endoscope. We can even ask the help of our ENT colleagues if we want a better success rate. So here we have used a drill as well in this patient. We have combined an external as well as an endoscopic approach. So Dacryology is a new thing wherein there's a micro endoscopy of the lacrimal system with a diameter of 0.7 to 0.9 millimeters only. Direct visualization of the canaliculi, sac and NLD can be achieved. There are two techniques to visualize it, the anterograde and the retrograde technique. So in the recent advances, this term image guided dacryolocalization has been coined by Dr. Javed Ali, and this has been considered in grossly distorted anatomies in traumatic NLD obstructions and craniofacial anomalies, and a 3D platform is also in vogue, so these have been tried. But however, I have not used these things for my cases. So in conclusions, all cases require a pre-op nasal endoscopy. Endoscopic guided probing provides excellent success rate. Endoscopic DCR is comparable to the success rates of external DCR. Thorough knowledge of the nasal anatomy and regular use of endoscopy, we should be ambidextrous as well, and then we can attain an easy transition to an endoscopic surgeon. Thank you for your patient listening. Thank you.
Thank you, Dr. Varsha, for the elaborate coverage of the topic. Do you do all cases endoscopic DCR, or how do you select cases for endoscopic DCR?
So basically, what we do a pre-op endoscopic evaluations for all patients. If the nasal endoscopy reveals a good roomy cavity, there is no deviated nasal septum, and the root of the turbinate is visualized well, then I go ahead with an endoscopic DCRs, provided the patient is okay with it. So if they are concerned about the scar, then yes. But the option is given to the patient. Mostly the young patients only prefer the endoscopic DCR. The other thing is we do under general anesthesia. So considering that as well, in older patients, we don't push for endoscopic DCR. We recommend an external DCR only. But for a younger patient with low risk for GA and all, we give the option to the patient.
Anyone want to ask anything regarding this session?
Yes, ma'am.
About the probing, I want to know
Yes.
what age up to you do probing?
Probing, usually we recommend conservative management rigorous massage up to 9 months of age. Beyond that, we recommend probing. And during probing, if in the type of complex LLDOs, like they might even get a buried probe or a hard stop, then we convert to an external DCR in the same setting. At the same time, even when the child, older child, say a 5-year-old or 6-year-old comes, then also when we do probing, if it is successful, we just go ahead with only probing with intubation and not a DCR. So
Age of the DCR?
Traditionally in the books they recommend 3 years, but the choice to do a DCR is based on the type of the block basically. So the earliest what I have done is for a 6-month-old child, wherein he needed a cataract surgery to be done, congenital cataract. So the DCR actually is not age dependent. So we can do it in a younger child. If it is a bony block and there is no canal at all, then there's no other way. But of course, we will have to diagnose the type of block.
Okay. Good.
Thank you.
Anne's paper talk has emphasized that if you have a mass, syringing is free or even partially free, take a CT, and you have to have a high index of suspicion in such cases. Take a CT. In such all cases, you have to take a CT. And we have a high volume DCR, external DCR. I think I myself have done more than 40 cases last year, I think. So, and we never send to the ENT. We never send to the ENT surgeon. You know why? So we do what I say is, if there is a nose, there is nasal mucosa, and you can do. If there is a polyp, we send it after. So so I don't think you should do endoscopy is necessary, because in our experience, we have never done an endoscopy before.
Okay. Endoscopy we only do, ma'am, in the OPD.
Yeah, if you only do, it's okay.
Yeah, so we do it. So only the cases which require an ENT surgeon's assistance, then we take. So it's like a grossly deviated nasal septum, then we recommend them only to do the DCR. Otherwise, the other cases, all the cases we do. So regularly we are doing nasal endoscopy. That is how I had learned actually, because every day around 4-5 cases of endoscopy we do. Then the surgery hands, it's not very easy initially to use both the hands. So when I used to do the endoscopy, only right hand I used to do. But we do the tube removal and cleaning, suctioning and all of that in the OPD as a daily routine when we did. Then we learnt it. So then it was easier. So initially it was like a sort of a mind block, like may not be able to maneuver the endoscopy probe. So but later it's actually quite all right.
And the most common cause of failure that I have seen is not opening the external DCR, repeat DCR, not opening the sac. You open only the periorbita. So the sac is not opened, only the periorbita is opened and it's anastomosis. That was
Yes, absolutely. Those are
and
the easy revision DCRs we get. So I'm very happy. SAC is not open, so it is a very good revision DCR to do.
But then whatever if you have difficulty, punch anteriorly and inferiorly. You will anteriorly and inferiorly towards the aloe of the nose, you will encounter the nasal mucosa, even in repeat DCR or any difficult DCR. After you encounter the ethmoidal mucosa, just give a push and then punch anteriorly and inferiorly, you will encounter the nasal mucosa.
Absolutely, ma'am.
Now, how do you manage lacrimal fistula in children?
In children?
Yeah.
So,
1-year-old.
So that we do external DCR only, ma'am, because anyway fistulectomy has to be done. So, fistulectomy with the external DCR. At the same sitting. So oh, you mean to say congenital lacrimal fistula. So congenital lacrimal fistula does not require any treatment unless the patient has Rho+ positive. So if it is Rho+ positive, then we'll have to manage the child.
Ma'am, have you ever encountered any CSF leak post-DCR, sir, during the surgery?
No, I have not encountered, but I have heard that it is definitely a possibility. As long as we don't punch around 2 millimeters above the medial canthal tendon, we are safe. But I always check whether there is any leak, but I have never encountered it. It's more so happens in endoscopic DCR, I've heard. So till now, touch wood, that has not happened. Drill, exactly.